I am Dr. Jeffrey Sterling, the Surgeon General for Alpha Phi Alpha Fraternity Incorporated. And I really want to applaud those of you that are watching this tonight. And it really is telling on your part that you're committed to health in all of its forms. These conversations that we have are really to empower you to be a better steward of your own health. So we're thankful that you take topics that you might not be versant in or may not necessarily think to be interested in. And tonight's topic is a great part of that conversation, of these conversations, excuse me, because everybody has heard about a root canal, but do you really know what it is? Maybe you feel like you've been threatened by it. And that's kind of the point. We want to eliminate misconceptions and give you information so that you can actually get the care that you need when you need it. There's nobody better to deliver that type of message to you than our Deputy Surgeon General for Dental Health. Brother Dr. Langston Smith has received his DMD degree from the University of Kentucky back in 1977, where he then followed that by joining the U.S. Navy and served 30 years on active duty. He completed the Navy Fellowship in Endodontics at Naval Dental Center in San Diego, California in 1983, followed by a residency in endodontics at Navy Postgraduate Dental School in Bethesda, Maryland. Dr. Smith is a diplomate of the American Board of Endodontics, receiving certification in 1992. Following the retirement from the Navy, Dr. Smith served as associate professor and chair of endodontics, at Howard University College of Dentistry for 12 years, retiring in 2019. All I can say about our Deputy Surgeon General for Dental Health is that he has been Alpha Man of the Year in 4 chapters and has received the Eastern Region Alpha Man of Merit. He has assembled a fantastic panel, and I applaud him as always for continuing to deliver information to the brothers, our families, and the communities that we serve. So welcome as always, Brother Deputy Surgeon General Dr. Smith. Have a great panel. We'll all be watching and learning.
Thank you, Dr. Sterling, for that introduction. And we hope and plan that we will address the various factors and issues that you have just mentioned, especially making our people more aware and educated on just what root canals are, dispelling some of the misconceptions, the misinformation and myths that exist out there. So good evening to all. Welcome. We're glad that you're with us today, and we've assembled an excellent panel to have this discussion. As Dr. Sterling mentioned, I am Dr. Langston Smith, Deputy Surgeon General for Dental Health, and I welcome you on behalf of our General President, Brother Lucian J. Metellus Jr., our Board of Directors, and of course, Surgeon General, Brother Dr. Jeffrey Sterling, and all of the Deputy Surgeons General. Welcome. We are glad that you are taking this time from your schedule to be with us tonight. Tonight, we will have a conversation between 2 endodontists and a general restorative dentist. Our topic this evening will focus on one of the specialties of dentistry, and that being endodontics. Why a discussion on endodontics? Well, during my years of clinical practice and teaching, I often heard from some of my patients, "Boy, doc, a root canal, that's the worst thing you can have." Or I heard, "Instead of a root canal, can't you just pull it, doc?" "Oh, doc, that's going to be so painful." Yes, I'm sure that based on some thinking that has appeared on various platforms, the thought of a root canal may make you fearful or uneasy. So ask the question, does the phrase root canal make you feel uneasy or anxious? Root canals have unfairly gained a bad reputation based on misinformation, misconceptions, and this will give a false impression of the root canal, that they are painful, dangerous, and not necessary. The truth is, root canal treatments are often more effective and safe. These common myths that they cause pain and illness should be avoided at all costs. The exact opposite is true. That, my friends, is why we will focus our conversation with you on the topic, endodontics, the real story of the root canal. Tonight's discussion will cover what endodontics is, the disease process, the role of infection and inflammation, why root canals are needed, the treatment procedures, medical concerns. We will address the myths and misinformation, and then we'll talk about what after root canal treatment and we'll address a special matter on root canal or implant. So if you have questions during the conversation, please place them in the comment section and we will get them addressed. Our panelists tonight, we're fortunate to have Dr. Todd Esther. Dr. Esther is the Associate Dean of Wellbeing and People, and it's a clinical associate professor in the Department of Cardiology, Restorative Material Sciences, and Endodontics at the University of Michigan School of Dentistry. Dr. Esther received his dental degree and endodontic training at the University of Michigan and holds a master's degree from the University of Pacific. He is a member of Omicron Kappa Epsilon, the Dental Honor Society, a fellow of the American College of Dentists, and a member of Alpha Phi Alpha Fraternity Incorporated. Welcome, Dr. Esther. Joining Dr. Esther, we have Dr. Matthew Gray. Dr. Gray received his dental degree from the University of Michigan School of Dentistry in 2011. He's in private practice at Restoration Dental Laser Center in Southfield, Michigan. Dr. Gray is an exceptional restorative dentist with a broad range of advanced training. Dr. Gray is a member of Alpha Phi Alpha Fraternity Incorporated also. And rounding out the panelists is Dr. Dontra Scott. Dr. Scott received his dental degree from Howard University College of Dentistry in Washington, D.C., and completed a general practice residency at Bronx Lebanon Hospital in New York City, and his endodontic residency at New York University. He is a board-certified endodontist and diplomate of the American Board of Endodontics. Dr. Scott is in private practice at Heights Endodontics in Houston, Texas. And Dr. Scott is also a member of Alpha Phi Alpha Fraternity Incorporated. So welcome, Dr. Esther, Dr. Gray, and Dr. Scott. And we thank you for joining us tonight to have this very, very important discussion. I'm sure that our audience is going to be enthused to hear your thoughts. And I will initiate the discussion with a question to all of you. You can bat it around. What is a root canal? What is a root canal? Who would like to take it?
Go ahead, Dr. Esther.
Well, I'll jump right on in. A root canal is actually the thing I love to do. And thank you, Dr. Smith, for such a great introduction for all of us. I'll tell you all, I've also been in practice at Renaissance Endodontics in Southfield, Michigan, where I'm a partner and owner for the past 21 years. And I love doing root canals. Root canals is the process of removing what we call the pulp tissue. Now, that is your nerve and your blood supply to your tooth. Think of it as a long bone, like you have the long bone in your body. Inside it, you have bone marrow. In each tooth, there is a space that's like a bone marrow. It's called the pulp. And the root canal process is where we can help save your teeth, keep teeth in your mouth. So gone are the days where we had to take out teeth and you have to have dentures like our great-grandparents did maybe. Now we can save your teeth. And root canals is a process to help you do that by removing that pulp tissue from the center of the tooth. This is a space that's highly vascular, and I will talk more about it, but you should also know there are stem cells in the pulp tissue. And so right now, the therapy around endodontics is a very dynamic space, and we're hopeful one day to be able to harbor those cells from the pulp tissue from your tooth and grow all matters of tissue in your body. So the root canal process, just to sum it up, is removing the nerve out of your tooth so that you can maintain your tooth and relieve any pain or inflammation that you may have coming from the tooth.
Okay. Thank you, Dr. Esther. What are some causes as to why we need a root canal?
Well, the most obvious reason you're going to need a root canal is caries. Caries is one of the most prevalent diseases in the world. All of us have probably had a cavity at one point or another in our life, or we know someone that's had a cavity. The caries have bacteria, and the bacteria travel towards the pulp tissue or the nerve, as Dr. Esther mentioned a second ago. And I always tell my patients, once they reach the nerve, it's like Thanksgiving. They're going to have a feast in there. And what they do is they cause inflammation and eventually necrosis of that tissue. And then that can cause you to have issues as far as inflammation or periodontitis of the bone. Another reason you may need to have a root canal is if you've had trauma to your tooth, whether that be a fracture, playing sports and you kind of luxated or, kind of put a lot of pressure on the tooth, or even a lot of times kids are playing around and one of the teeth get knocked completely out. So that also could be a reason why you need a root canal. And then bringing in Dr. Gray here, you may need it for restorative reasons. Believe it or not, about 20% of all teeth that have a crown on them will need a root canal at some point. And then for people who are using some type of denture, whether it be a fixed, like a bridge, or you're using the tooth to hook your denture on, you got about like a 30% chance of that tooth also needing a root canal. So those are kind of your main reasons why you may need a root canal.
Okay. Dr. Gray, would you care to elaborate more on the restorative, on root canals in support of either restorative prosthodontic needs?
Yes, I was going to say you two have covered most bases here, but yes, as far as restorative needs, with a lot of times, like Brother Scott said, when we're doing crowns, sometimes we need the space. Sometimes people's bites have collapsed, and we don't have enough room to put a crown on without disturbing the nerve of the tooth. So we could put a crown on a tooth, trim it down for that. And then we're in the nerve space. So having the root canal would help with that. Other times, like was mentioned, if there's trauma to a tooth and we need to put a crown or a bridge on a tooth where we're connecting two teeth together to fill in the space for another tooth, we need that root canal done to build that tooth back up. So we'll have the root canal done, and then we'll put oftentimes a little fiber post down into the root canal space where we can then build upon that and have some anchorage there. So there's a lot of needs, and then as was mentioned with dentures, hopefully we aren't in the need for dentures, but sometimes when we are, we can do root canals, and we can, instead of using dental implants to hook dentures to, we can actually do root canals and put what's called locators. They're little devices that can be placed down into the tooth root after the root canal is done, and we can then attach dentures to that to avoid having to go through the costly process of doing a dental implant or even just taking the teeth out for that.
Okay, well, thank you. One of the things that we talk about all the times is saving the tooth. The root canal is going to save the tooth. Why is it important? Why is it important that we maintain that natural tooth? And who would like to attempt and discuss that?
So, I'm gonna jump in there as the restorative guy. I say this several times a day to patients. A lot of times people just think, just pull it out, doc. And I say, no. There's nothing like your natural tooth, your tooth. I can put in an implant, and implants fail. People think an implant is a final thing, but they fail. Nothing works like in your body the way your body is built naturally. And so when we keep that tooth in your mouth, it's so much easier to work with your tooth than trying to put something artificial in your mouth. So if we can do a root canal, save the tooth, keep it in there, you're going to be much happier.
Okay.
And if I could add to Dr. Gray's great summation on that, and get a little feedback. Sorry. I would just also say the importance of the tooth in preserving the bone, right? So we talk about bone levels, and many times, again, I'm gonna pick on our great grandparents and our elders today, but our great grandparents and some of us who actually wear dentures or partial dentures, over time that bone atrophies. And that bone will go down. It will be actually to a point where, and you may recall, great big mama or big daddy taking their teeth and put them in the jar, and they just sit in that jar all the time. I don't know if anybody know that, but my grandparents did that. And so what we can prevent by maintaining the tooth is keeping that natural level of the bone, so you can still place a device like a denture or an implant so you have enough bone. You also helps with your chewing, with your aesthetics. It also helps with the way your thirds of your face look, so you have that youthful look. So a lot of times for the brothers and sisters on the call who like the way they look, think about the aesthetics, and that comes from maintaining the natural levels of your bone, and teeth also help to do that. And so to add to Dr. Gray's great summation around why we keep teeth, think about preserving your bone levels and all the great things that come from that in the natural way and that youthful look that you have.
I don't know why our community. I guess I do know why, but for some reason we were just told to pull the tooth out when it got diseased. For whatever reason, obviously maybe treatment was expensive or there wasn't a specialist around or what have you. But I always like to put things in perspective for people. You know, if one of your fingers got lacerated severely, or one of your feet, you know, would you want me to the doctor just to chop it off and you know, tell you to go on your way and put a fake one on there? No, you would try to do everything you can to save that part of your body. And the tooth's no different. That's what you have specialists for. We're here to help you maintain that quality of life by keeping that natural tooth.
Okay, great discussion, brothers. I often hear that root canals are extremely painful. This is one of the myths, one of the some of the misinformation that's out there. And it is true that there are some times when we treat a root canals, the patient is in pain. So what is it when a patient comes in pain and we need to do and a root canal is needed or required? What's the cause of that pain? Why is it painful?
Well, I think we got to start off with the biological basis of it. Like we touched on before, most likely bacteria is the reason why you're having the symptoms that you're having. There are a lot of like historical studies done by famous researchers that show you that bacteria with that necrotic pulp, or the pulp that's kind of lost its vitality, will cause you eventually to have inflammation, not only in the tooth, but then eventually in the surrounding bone. And it's painful. I'm not going to sit here and you know, sugarcoat it. If anyone's ever had a toothache, even a minor one, I'm the type of individual I can notice right away if I even have an occlusal caries. I know something's off, you know, so I can imagine what it would be like for it to get to the pulp. But your own immune system recognizes these bacterial products as foreign, and your immune system is doing what it's supposed to do, which is to get rid of it. But the byproducts of your body getting rid of it are pain and swelling and, you know, signs of infection. So that is the initial reason why the area just doesn't feel, you know, comfortable.
And Dr. Scott, if I can add to that, and thanks for that biological basis. And let me just give you the just the layman's level of what's going on. The misnomer, you talk about the myth, Dr. Smith, and I thank you for saying that and calling it a myth, because people think about root canals being painful. But what Dr. Scott just so eloquently just stated for all of us is the pain is already there. The root canal takes away the pain.
Right.
And that's the misnomer. And I, brothers, I know you all do it as well in your offices. Every day, I'm constantly having that conversation. I'm here to take your pain away. Now, we know the healing comes from above for those who believe. But the actual process of getting your body in the space to heal itself, that's what we are helping you do by removing that inflamed, that infected tissue so the body can then do its masterful job of healing. So always think about the fact that the root canal takes your pain away. We're not causing the pain. Many times our patients come to us with pain. And so I think that's the first step in helping to kind of bust that myth, if you will, around the fact that what the process is doing is removing that pain and getting you back to health and good oral health in your body.
Okay. But Doc, you gave me anesthesia, and the anesthesia isn't working. So how do we address that to the patient in layman's language?
So you're not going to make this easy for us, Dr. Smith.
He's getting technical.
Okay, I think our audience needs to know that.
So I like to make people feel comfortable by trying to break it down like Dr. Esther did, like in the layman's way. So we give local anesthesia, which is everyone's least favorite part of going to the dentist. I know no one likes the needle, not even me. I know it. But it's necessary evil because that medication is going to go into your body and basically put those nerves that are firing and causing all that intense pain to sleep, at least long enough for us to do what we got to do so your body can start the healing process. Now, the local anesthesia sometimes take longer for people who have infections because of a lot of chemistry that I'm not going to get into. But when you have infections, the medicines, they just don't work the way that they normally do. So that's why we encourage our patients to be preventative and try to get to your doctor before the area gets really inflamed and really painful. But really quickly, I do like to let patients be educated as well. If you're getting a root canal on a lower tooth, your doctor goes in and gives you that numbing, they shouldn't touch you for at least 10 minutes. They got to let that numbing kind of set in and start to work. If your doctor comes back in the room in less than 10 minutes, tell them to go back out.
Time is our best friend. That's for sure. Time is our best friend.
Very well put, Dr. Scott. Very well put.
And then another thing I like for patients to educate you as a patient, tell your doctor to test. other things and make sure that you're all the way where you need to be. Check, especially on the lower upper teeth, they go numb pretty much instantly, but those lower teeth, they take longer and they're harder. Tell your doctor to test the other areas, make sure that they're numb before they just start putting the drill to you there.
I love that. And I just got to jump in on that because this is our challenge as professionals, particularly as endodontists, because we're going right where the nerve is. And so also in that education for our patients, we let them know we're doing multiple levels of anesthesia because we're a referral-based practice in endodontics. So many times our patients come from a general dentist or another practitioner who's seen the patient, they refer them to us. What's so interesting, I'll hear patients say, at least 25 to 30% of our patients will say, I couldn't get numb in my dentist's office. And so they're already bringing us the most challenging cases as specialists. The important part that I always share with them is we get multiple levels of anesthesia. The block is the first step of numbing you up or making you numb. But the next step is the intraosseous technique, going right around that tooth. So we can buy that time, as Dr. Scott just alluded to get into that tooth and get that nerve out to give you that relief that you need. So we're going to employ multiple levels of anesthesia. In some cases, we'll even give an oral analgesic to make sure that you can relax a little bit. In some cases, if that's necessary, but we will do whatever's necessary in that particular case to make sure that you're comfortable for the procedure and not going to be in pain. And so I think also when you talk about that, Dr. Smith, bringing in those patients coming with the difficult numbing issues, we already have been well trained in being able to make sure that we have maximal anesthesia on board before we start to even touch that case.
Dr. Esther, I'm stealing that explanation from you.
Matthew, it's all for free, my friend.
Okay.
Can I jump in and ask a question here?
Yeah, sure.
I was going to ask to you, how you feel when I have patients that I oftentimes just get them started on an antibiotic when the tooth is like that. I just, I say, here, let's get you started on this. I'm going to see you in 3 or 4 days.
So
Yeah.
I'm going to have to go back to the evidence and the science. If there are no signs of systemic, infection, then the use of antibiotics has been shown not to do anything as far as what you're trying to achieve as far as getting that anesthesia in the area. So that's my first thing. I always like to educate my referring dentist. Only use those antibiotics when you know that patient's infected, because you might need it one day and it may not work. But one thing you can do, as Dr. Esther pointed out, is maybe doing some type of pre-medication. Give your patient some ibuprofen an hour before you want to give them the injection. Sometimes we even have to employ steroids if that's needed, to get the patient numb. And if those things don't work, then you might have to go into other layers of technique as far as the anesthesia goes. But the antibiotic per se, unless that patient is swollen, out to here, and pus coming out or things like that, high temperature, I would avoid using it. It's not giving you the results that you think.
I totally agree with that. And I'm so thankful, Dr. Gray. And I want to just also say, because me and Dr. Gray are in the same areas, we actually share cases together. Okay. And I want to say thank you, because a lot of times you do make sure you manage those infections before they come to us. And so as Dr. Scott just alluded to, if the patient is swollen and infected, get them on that antibiotic, because then by the time they get to our office, they already have some relief, and we can, in many cases, go ahead and treat them that day. As the science shows us, it is best to get that infected nerve tissue out as quickly as possible. So we're not going to wait necessarily trying to do that case if we don't have to. But in some cases, based on the patient demeanor, based on what's going on with the actual case as far as swelling is concerned, there may be other steps we need to take before initiating that root canal treatment.
And I put that out there because I get at least one call a week. And doc, can you just prescribe me an antibiotic? I have a toothache. I know what it is. And I said, no. Let's come on in and see what's going on before we put you on anything, or we need to just treat the tooth. Fantastic. That's why I put that. Yeah.
Yeah, that makes me smile to hear you say that, Dr. Gray, because not just dentists but patients too. They just think, get an antibiotic, everything's going to be better. But in fact,
it's a cure-all.
Yeah, exactly. We're making the situation worse. We're giving the antibiotics like candy.
Well, mentioning antibiotics, I want to go back to my days of practice, and when there would be individuals that would say, we want to send this case to you, but we're going to open it up and leave it open for a few days. And I know what we're getting into. So, Dr. Scott and Dr. Esther, what are your thoughts? What are your comments?
There are no scientific articles that have been credibly found to show leaving the tooth open is an advantage to the patient. What happens many times by leaving the tooth open, it reintroduces other bacteria from the oral cavity. So without getting too deep about it, but I'll just say other bacteria. So we try to keep the bacteria that are causing that infection. If the tooth is open, now it's open to other bacteria in the mouth. And we know our oral flora have a plethora of antibiotics. They actually are some that are very healthy for us, right? They help us break down our food and digest and to take care of certain parasites that are in food or in our mouth. So they're very helpful, but they're not helpful when they get down into the tooth in a closed space. And they become very virulent in those spaces. And so we definitely would ask you, please, I don't know how many of our fellow colleagues are on the phone on this call tonight, but leaving a tooth open is not necessarily what we want to do unless we're going to be observing and watching that case in our office with you for a period of time while you're draining with a rubber dam on the tooth. And we haven't talked about rubber dam yet, but you know we're endodontists, so you know what's coming. But with a rubber dam, an isolated tooth, so we are not introducing new bacteria into that case. The more bacteria that can get into that case, the longer many times we see the healing of that case takes. And so we want to definitely eliminate the issue of leaving the tooth open for draining.
Okay, thank you. We've talked a lot now tonight about the root canal, why we do it, and all of that. But can we go into a format here clinically? How do we do the root canal? And, if we go back in time, we've made there a lot of technological clinical advances that make root canals much more reasonable now and less traumatic. So how do you do a root canal?
Well, I like to always start off with the diagnosis. When you go to your dentist or the endodontist, we're going to take radiographs or x-rays, all right? And now the technology is so advanced that the concern of radiation should not really cross your mind. We're taking very minimal x-rays, different views so that we can see different things. And then most endodontists have what's called a CT machine. It's very similar to what you would get at a medical hospital, but it's been transformed so that it reduces radiation so that the dentist can use it. And in my office, my CT machine only takes a picture of that one little area. So it reduces that radiation even more, all right? I like to tell patients it's like basically taking that cross-country flight from New York City to LA. That's how much radiation you're going to get from my x-rays. And then we're going to do a diagnostic exam, test the tooth, the pulp, and then the tissue, the bone that surrounds the pulp. And then we're also going to be looking at that tooth to make sure that after we do the root canal, the tooth can actually be saved by a crown, or some type of restoration, because there's no point of doing the root canal if, we can't, build it back up and save it. So I just want to start with that part, and I'm going to then pass it over to Dr. Esther.
Well, thanks. And so the next step after we've diagnosed the tooth and have a diagnosis that's synonymous with needing a root canal, our next step will be to get the patient numb. And that's where the fun begins because, I always tell the patients for them, that's probably what they would consider to be the most psychologically difficult part. But I always love it after we give that topical anesthesia and let that sit in their mouth and make sure that the tissue we're going to inject them in is already very numb before we go in with that injection. Many times they're like, "Doc, you're done already with the anesthesia?" And I'm like, "Yes." And they're like, "That wasn't bad at all." And I'm like, "Good, we're friends now. Let's go. Let's go. We can get this done." But the next step is getting them numb, and we make sure we have profound anesthesia. And so I like to use that word very clear with our patients. We're not touching. You heard Dr. Scott allude earlier, 10 minutes sitting time in the chair, at least or more, to make sure that they're fully numb, testing areas before we go in with any kind of instrumentation to make sure they're fully numb. You're going to be numb for the ride with us during that root canal procedure. After that's done,
I say, and after.
and after, that's for sure. After they're numb profoundly, then our next step is to make access to the tooth. Many times that's through the occlusal surface or the biting surface of your tooth. If you think about your back molars and the top part of that molar that you brush with your toothbrush, that's going to be the space where we're going to actually go in and make a tiny opening in that tooth. In many cases, as already said by Dr. Gray and Dr. Scott, there's already a cavity or a caries on the tooth. And so that opening has been started for us in many cases, right? And so, but we're going to increase that opening to make access to that center part of the tooth where the nerve resides. We use a mixture of fluids and chemicals inside of the liquid to make sure that we can get what we call a mechanical, chemical cleaning and shaping of the canal. We use various types of instrumentation that goes pretty quickly for patients, and they're always amazed just how fast the process really is. Our goal is to make sure we clean and shape from the entirety of that canal space. And once that's achieved, then we're going to dry the space out. We'll take a few radiographs in between it, and then we will pack the canals back with what we call a filling material. The name that most of us use is gutta percha. It's just like the best synonymous thing to talk about is like the gutties of a golf ball. The inside gutties, people sometimes have heard of that. It's like a material that's very easily reproducible. We can retrieve it out of the tooth if we need to. It's also visible on our radiograph, so we can see where it's placed inside the tooth. And what's so nice about it, it changes its forms for us so that we can actually pack it and condense it down to fill the space of the canal. Once we've done that process, which takes many times anywhere from 15 to 25 minutes to clean and shape out the canal and close the tooth back up, we then send the patient back to their referring dentist to have the core filling and then a crown placed on the tooth in many cases.
Okay, thank you.
I missed your name, Dr. Scott. You want to add to that,
Yeah,
please?
there were two things in particular that were not mentioned for me, at least. So when patients come see me, I try to make the patient be as relaxed as possible. So I'm going to offer you some type of, maybe like a nitrous oxide or something to relax you. I'm going to give you what's called a bite block. That's going to basically support your jaw open. So that way I can have access to what I need to do safely. And also it just helps you out as well. And then the last thing, he mentioned it, but he didn't say it in this last segment, was the rubber dam. Whenever you get a root canal, no matter who's doing it, they should be placing a piece of plastic basically over your mouth and over your tooth. It should feel like you're wearing like a mask. If someone's doing a root canal on you and they don't put that mask over you, they are not following the standard of care. So do not let them proceed. Ask them, where is your rubber dam? And that's just going to isolate the tooth, prevent any new germs from getting in. But it's also very much for your safety, so you don't swallow any of the small little instruments that we use, or you don't ingest any of the medicines or chemicals that we use to disinfect the inside of your tooth.
Okay. All right. So killing bacteria is critical to the success of root canal therapy. Dr. Scott, you mentioned testing the tooth. And can you share with our audience how do we test the tooth?
So when you come for that consultation examination, we're looking for both the pulpal status, meaning how is your nerve responding, and then also how's the bone that's surrounding the tooth. And another thing, like I mentioned, was can the tooth be saved with restorability, meaning can we rebuild it? And then the fourth component of that is the gums, like your bone that's surrounding the tooth. So I'm going to go in, I'm going to measure your gums with that little probe that everyone hates, where we kind of stick it in and measure, calling out your numbers. I'm going to test your tooth out to see if it can feel temperature. Both the intensity and how long it feels the temperature matter. And if it doesn't feel any temperature, it also matters. Sometimes I have to use some type of electric tester to see if we get any response. And then what we're going to do is we're going to be doing a bunch of tapping on the tooth for layman's terms, and having you bite on certain parts of the tooth to see how it responds. Sometimes I use little special lights to see if there's any cracks, or I might stain the outside of the tooth to see if there are any cracks in the tooth. And then I'm going to compare all of the results I get from that examination to what the x-rays show. And then also I'm bringing in that 3-dimensional scan that I mentioned earlier, putting all that together based on what you've told me and what you told my assistant, and she kind of whispered in my ear, that I'm going to be able to figure out, exactly what's going on.
Okay. All right. Thank you. Thank you very much. Now, we've diagnosed the tooth and know that it needs a root canal. We have treated the root canal. What next? How is this tooth restored, and why should it be restored? How important is restoring that tooth, and what are some restorative processes?
So I'm gonna, as Dr. Esther had mentioned, he said once we're done, we package it up and send you back over to the restorative dentist, which would be myself. When I send a patient over to the endodontist, I expect that we get a letter back from them. They always communicate with us, so make sure when you do go from your general dentist to the endodontist that both of them are communicating with each other. Because we want to know what's happened to you there, and a lot of times you don't remember what happens, or you don't remember what we call it, and patient's amnesia, where you get out of the chair and you forget everything that we've told you and everything that they've told you, and so it's good for us to be communicating. You come to our office, what we do is we, at least in my office, what we do is, check the tooth. I want to see the x-ray after that they've sent. And oftentimes I'll look, verify it's the right tooth that I sent you over there for, verify that, that make sure that they didn't send any notes saying anything else was going on, that we needed to keep an eye on another tooth. And then we'll go in and I like to isolate that tooth. In most cases, afterwards, we don't go so far as to use a rubber dam again, but we get gauze packed around there. I have my assistant with my suction right up next to that tooth. I don't want anything getting in there, because when I open up that tooth again, they've done the root canal, they've cleaned it out. And so I want to keep that area as clean as possible. They stay right there. And if I have to hold their hand to do it, that's what we do. And I go in and then we take out the packing that they've put in there for their access, because what they do is make a hole. And I love, it amazes me every time the size holes you all can get away with doing root canals through. If it's me, I have the whole tooth opened up. You guys can get a tiny little pinhole and get all 3 canals or 4 canals sometimes. And so then we go in and we put a filling material, which we call Dr. Esser mentioned, it was called the core. We put that in there. What that does is that fills in all the space that was removed either from decay or just from them having to make access to the nerve chamber. And then after that, the plan is that we then plan for that tooth in I would say 80% of the cases that we're planning to put a crown on that tooth. And the reason we put the crown on the tooth is because fillings fail. That's what I tell, that's what I let my patients know. Fillings fail. And so you don't want to have all that work done, and over time, the tooth, the core that's in there, it can leak and it can reinfect that area. So what we do is we take that tooth, we put the core in there, and then we prepare it for a crown. So that creates an extra layer of support and structure for that tooth. And then also, as was mentioned, the nerve supply of that tooth has been removed. The vitality of the tooth is gone. So I describe it to my patients as though you have a tree and you've cut off its roots. And so eventually what happens to that tree is it becomes brittle. And in most cases you can hit a tree and it'll bend and it'll kind of, if it has its roots in there, it'll be pretty sturdy. But if you take the roots out of the ground for the tree, it's going to break. It's going to become brittle and it'll snap. And the same thing happens with teeth. And we see teeth fracture because they just don't have any vitality to them anymore. They have no nerve supply. So we protect that tooth structurally by putting the crown on top of it. And a lot of times, if you've had decay, you've lost a lot of tooth structure. Oftentimes, you may have lost a lot of tooth structure as well. And that's why I said in most cases, about 80%. If it's an anterior tooth, I look at the location. When I mean anterior, I mean anything between your canines. In those cases, oftentimes, if it's just a small access for those, we will put a filling material in there. And in those cases, I put a separate filling over top of where the canal is, and then I put another one on top of that, and we just monitor those because I don't worry as much as those fracturing. And you guys may jump in as far as if I'm miss something as far as that.
Any other comments? I do have a question. What are crowns the only restorative? Is a crown the only restorative procedure that we should use on a tooth? And I understand exactly what you said, but say the patient comes in and said, "Doc, I afforded the root canal to save the tooth, and now I just don't have the wherewithal to pay for a crown." Is there an alternative restoration?
In most cases, I would say, like, for me, what I would say in those cases is we can work with you. I have put temporary crowns on patients to help them out to hold over until we've gotten the permanent crown on. We have put cores in and just closely monitor the patients. Oftentimes in those cases, I'll see the patient a few times before we end up putting the crown on the tooth.
Okay. Any further comments on that?
No, I don't have a comment. That was a masterful job by Dr. Gray.
Right,
Just
exactly. Very good.
the one thing I think I would just add is just that topic of tooth becoming brittle is a very contentious topic between endodontists and restorative people. And Dr. Gray is right. Many times, because of the forces that a tooth takes, getting those posterior teeth covered with a crown, we fully recommend. But the question is, patients should know that the tooth is embedded still in the alveolar bone or their jawbone, which is still bathed with fluids and a periodontal ligament, and it still has capacity to not become a problem or a nidus of infection or a reason that that tooth won't be able to heal well over time. And so I think that's just something also I just want to make sure our audience gets a chance to understand. Having the root canal, the tooth still has viable life inside of the bone. It just doesn't have a nerve inside of it. So you won't feel hot and cold sensations, particularly on a tooth that's had a root canal. You should not be feeling any kind of thermal sensations to your cold drink or to your hot tea or coffee after a root canal has been done. But definitely the tooth still has a good viable life and a good prognosis for future viability.
Okay. A good conversation. Thank you, Dr. Gray, for that discussion on restoring the tooth and for that addition from Dr. Esther. Are there any medical contraindications to root canal therapy?
I don't have any contraindications per se about the actual procedure itself. It's more about medications that we may need to use during the procedure and after the procedure that most concern me. And then also just the patient's, well-being. Are they able to, sit through the procedure? An endodontist is probably going to see you for about 45 minutes to 2 hours at the most if it's a super difficult treatment. So that would be my main concern as far as medical contraindications. Mainly my cardiovascular patients. I want to know, are they able to use epinephrine when I use my local anesthesia, just so I can achieve that profound, long-lasting anesthesia by using the epinephrine. So I have to often get medical clearance from their doctors because of that. And then other comorbidities may affect how you heal after the root canal treatment. People who are smokers are going to not have been shown to not heal as well. Our diabetic patients often have increased delayed healing, I should say. That's been found over and over again. And then, like I said, the cardiovascular issues. Those are my major concerns. And then patients who may have some type of like osteoporosis or something using those bisphosphonates. Obviously, we want to offer them the root canal treatment if we can to try to avoid any bone surgical procedures. But for me, I want to help my patients. If they're in pain, there aren't too many reasons why I can't, do that. At least get them out of pain.
Yeah, I love that, Dr. Scott. And if I just could add to it, I think this is a good opportunity to highlight the relationships that take place between practitioners. There's conversations that are happening, and Dr. Scott just named it. We'll send a medical consult, to their cardiovascular physician, their internist. Sometimes patients who have histories of implant will talk to their orthopedic surgeon because sometimes they will want them to have pre-antibiotics before the procedures. And many times those cases with root canals are not warranted. However, the patient and the physician may want them to still have an antibiotic. There are some bacteria from the mouth that can travel to sites, such as some of the sites that have been transplanted sites. And so we'll still, in some cases, give a patient antibiotics. So Dr. Gray alluded to as well the conversation that happened between the dentist and communicating how important that is. But also, this is where clearly the head is connected to the body. And many times your physician is going to be hearing from your specialist or your general dentist to make sure that you're safe for treatment. And I think that's an important piece to name. But definitely, as Dr. Scott said, many times the physician will sometimes refer back to us to say, get that root canal done. In COVID, for example, endodontists and oral surgeons were asked not to close their offices during the COVID period because they didn't want patients running into the hospital for something that could have been treated in the dental center. So our practice in Michigan was opened only 2 weeks. We were closed during COVID. The rest of that time, we were open and available to our patients, even during the height of the pandemic, to try to keep those patients from having to go into the hospital centers or the ERs to get service that we could take care of in the center. So the relationship between physicians and dentists and all of your healthcare team is so important. And many times we'll be communicating to your healthcare team to make sure that you're safe for that treatment.
Thank you, Brother Esther, because we did get a question, and it says, root canals after joint replacement surgery, are antibiotics required? And I think you just addressed that in some cases they are, some cases they're not, depending on the communications between the endodontist and the orthopedist. So I think that you addressed that very well.
I want to do real quick, Dr. Smith. I know it's mostly brothers on the call, but for your wives, or your daughters, they're pregnant and they've got, severe pulpal inflammation or necrotic tooth or abscess. Tell them, even though they're pregnant, they should still go see the specialist or their dentist. Like I said, there are no severe contraindications to pregnancy and root canals either.
Okay.
Thanks for saying that, Dr. Scott. This is getting fun because, again, we don't get a chance to talk as practitioners like this a lot of times. So, audience, bear with us. We are dental nerds. We love what we do. But just the ideal of that, Dr. Scott and Dr. Gray and Dr. Smith, the ideal that patients wouldn't come in, right, because they have a problem that can be treated. That's something in our community that we address a lot. My practice is right outside, a mile outside of the Detroit line, right in Southfield. The majority of my patients are, at least 80% are African American. And I'll tell you, when they come in, they see practitioners who look like us. Many of them will say thank you, because the communication, the conversation, and the trust that they have many times, because we're going to spend that time chairside to talk to them through their case and make sure they're covered and they're safe and that they feel comfortable with our team in our office during that case is so important. So being able to get people in, I think that's a great reason to say why we need more people who look like us, African-American men in particular, but our women, of course, as well. But we need, right now, there's a lack of men of color in dental education and healthcare education. And there have been studies that have shown outcomes for patients, particularly health outcomes, even life expectancy increases by having a Black physician, and if oral health care is better and patients feel more comfortable with people who look like them. And so we have a need to recruit more and more of you into our profession. So hopefully tonight we will win some of you on the call over and say, I'm going to look into dentistry and maybe even endodontics. So I just wanted to just put that plug in because it's a great chance to talk about how the team works and how we're all vital to the team and how we're needed in the profession.
Okay. As we move into the final minutes of this discussion, I'd like to talk about implants and root canal therapy. Over the past 30 years, 40 years, we have made tremendous strides in implant technology in dentistry, and I think it's going very well. But I've often heard back when I was teaching, some students say, no, I don't want to go into endo because endo is going to be lost because implants are going to take over. And I think when we look at some of the research, we're showing equal successes with implants and with root canal. The one from some of the more current research that I've just read, they're about equal in their success rates. So I want to throw this question out. At what point in time should you consider implant rather than root canal therapy? And let's have that discussion. Implant, root canal therapy.
So from my perspective as an endodontist, I always ask the patient one question. Do you want to try to save this tooth? If you want to try, then we know what we got to do, and if you don't want to try, then this is your only option. You got to have that tooth extracted. But for me as a endodontist personally, this is just my personal opinion, low level of evidence. I'm only going to tell a patient to pull their tooth out if it's cracked like all the way through. Like if I go under the microscope and I see that crack all the way through, I just know that the chances of success are pretty low. That's the only thing that I can scientifically tell you that, you have a very low chance of success. But everything else it's kind of case by case, patient by patient, and tooth by tooth. So that's just my personal recommendation. But I do want to really quickly touch on implant research. I actually just came back from the University of Pennsylvania with Dr. Kim, and he was telling us, pointed out, which is really important, the studies that are comparing implants to endodontics is two different things that they're measuring. With us, endodontics, they look at the x-ray and see if that affected bone actually replaced itself and healed, and that's what they call success. With implants, they look at how is the implant still actually there, and they actually call that survival. So survival and success are two different things when you're kind of weighing the two against each other. So I just want to point that out to the audience.
Yeah, and I just have to jump in on this one because it's so important. I think, and it was said earlier by, I think, Dr. Scott and Dr. Gray, that the natural tooth is your best implant. So we can maintain that tooth in your mouth. Again, we talked about the bone levels, your alveolar bone. We talked about the health of your gum tissue around that space. We can maintain that natural tooth in place. That is your best implant. Let alone, we're not even talking about cost concerns, and those may have some also compelling interest when you think about the cost of the treatment. However, if we can keep your natural tooth in place, that is your best implant. And so many times, again, and Dr. Scott said it so well, it comes down to what the patient's goals are and the general dentist goals. This is where, again, that team approach, many times that the referring dentist will send the patient over and say, can we keep this tooth, or can you talk to the patient about trying to maintain the tooth? I've had oral surgeons, those are the individuals who will extract teeth for the most part, along with general dentists and others. But however, oral surgeons refer and say, you know what, I'm not taking this tooth out. This tooth can be saved. We should keep it. And so I think we as oral healthcare professionals would agree, keeping the tooth in place is really our goal. But in cases where it does need to come out, then that's where we find ourselves taking out, and then it becomes the next best procedure. So again, I think we're all clear that for at least the two endodontists and maybe the general dentist on the call, I want to speak for you, Dr. Gray, but we will rather keep that tooth in the mouth if we feel that it has a favorable prognosis, meaning over the next 2 to 5 to 10 years, this tooth will still be viable in your mouth.
Okay, well, thank you.
I was going to say, I was going to jump in at the end here. I agree with both of you, especially as you said, Dr. Scott. For me, it's always, of course, up to the patient what they would prefer once they've been presented all the information. But for me, if the tooth is fractured, and it's non-restorable, to me, that's the only time I would say, okay, we don't have another option. And oftentimes when I'm seeing patients, it's, either a lot of times like they're needing a retreat and I'm sending them over there. And those are the times when I'm on the fence. Often. I do send them, like you said, Dr. Esther, I do send them to you guys and say, can we restore this, or what do you think the prognosis of this tooth is? Because I place implants and I do root canals, and I see failures in both of them. And so implants, everyone thinks it's the magic tool to put in there that's just going to replace their teeth, but they come with their own problems. There's aesthetics, there's cleaning issues, there's all sorts of things, and so it's not just a cure-all, and it comes with a price. And one of the things that I do tell my patients is, I don't like to jump to the last resort. First. I like to keep yes, exactly, first. I like to keep that implant in my back pocket if I need it. Now, let's start with trying to keep your tooth. If we can't keep your tooth, and we've tried the root canal, we've tried everything else, as long as the patient's up for it, I'm willing to try all avenues to save that tooth before we go to the implant.
Okay. All right. Thank you. Very, very good conversation. Very interesting conversation. And I like the points that you brought out in looking at both the implant and the root canal. Okay. Why do root canals fail? What are some reasons that root canals may fail? And how do we address those cases?
So Dr. Scott earlier talked about bacteria being the cause, and I think that's still the primary reason in most of our research that still shows why teeth fail, because bacteria getting repopulated down into the canal space. How does it get there? It can get there through, the filling. If for a reason there's another cavity that formed on that tooth after the root canal was done and the crown was placed or a filling was placed, the tooth still has a surface that can be decayed. And so decay can still get under the crown, get around those open surfaces of the tooth. That bacteria can find itself back down the canal. We still find that's the primary reason for endodontic failures is bacteria from decay or from a leaky restoration around the tooth. Secondary, we find is a fractured tooth. And again, we talked about that earlier. If the tooth breaks or fractures, then that will also cause a need for, again, we'll see on the radiograph an area around the tooth. We may see mobility of that tooth. There may be swelling associated with that tooth. Those are some of the signs and symptoms that you'll notice after a tooth fails. I want to just circle back, if I can, real quick, and I'm sure Dr. Scott and Gray may want to say something about why teeth fail, but I want to circle back. Another part of your question earlier, Dr. Smith, was around endodontics may be becoming obsolete because they're not going to be needed. And I think we didn't address that. And what I want to say to that is that I see many children now in my practice. In the state of Michigan, we have Healthy Kids. That's the Medicare delivery in our state. I see at least 45 to 50%, me and my business partner, who's also endodontist, of children now. And so you'll be amazed how much decay is still found in our environment, particularly those who don't have insurance or may have Medicaid insurance. So changing the habits of patients, putting the baby to bed with milk in their cribs, or sugary foods, for kids drinking pop and sodas too early, not brushing your teeth and flossing properly. These are some of the reasons that still teeth get decayed. And so that is not going anywhere, unfortunately, and that's going to cause a problem. The last thing I want to say is this whole issue around fluoride in the water is also, we are predicting in the next 5 years to see an increase of over 60% of decay in children just because of the lack of fluoride in water now for those states who are now not putting fluoride in their water. We saw a great reduction in the amount of caries for children, particularly because of fluoride was in the water. And so these issues are issues that are still very concerning, but that is the reason why endodontics, dentistry is not going anywhere. As Dr. Scott said earlier, one of the largest, most pervasive diseases in our bodies is dental decay or caries. And so that's something just to think about. And for all those potential dentists on the call, think about endodontics, because we are busy like all get out. Even though 90% of the root canals are done by general dentists, our offices are still overflowing with patients because decay is going nowhere.
Okay. Well, gentlemen and brothers, I think the time on the wall says we have about run out of time. I want to thank you so very much for sharing your information and your expertise with us tonight, and give you each 1 minute to do a final wrap-up statement.
All right, I just want to wrap up my statement with saying that root canals are not painful if they're done correctly and you're profoundly numb, and they will help you maintain your natural tooth, which is a very important part of your body. Maintaining your oral health with preventative measures, brushing, and at least flossing at night will reduce the inflammation in your body. And there are tons of new studies that are coming out that are directly linking oral inflammatory disease in your gums and in periodontal tissue, meaning the bone around the teeth, with other comorbidities, especially in our community as African Americans. That inflammatory process can lead to cardiovascular issues. It's even been linked to Alzheimer's and dementia. And for all the brothers on call, it's even been linked to ED. And we know we don't want that. So make sure we're brushing our teeth and flossing at night and maintaining good oral health.
I'm going to jump in. I'm going to keep it short and sweet. As you guys have heard from the specialist here and myself, don't be afraid to get a root canal. Don't just say yank it out. We want to keep our teeth. Once you take them out, you don't get them back. And best ways to prevent that from happening, as Brother Scott just said, make sure you're brushing, flossing, coming to see your dentist at least twice a year for your checkups and exams. And when we make recommendations, don't be afraid of getting the filling, because what I always see is the filling, the slight little bit of pain turns into a little more pain. I don't see you for 6 months or maybe a year. Next thing you know, you need a root canal, and that's when you come back to see me. And by that time, hopefully, I can send you to the specialist or take care of it myself. And so we want to prevent those things by preventative care, which is brushing, flossing, and fluoride mouth rinse.
Thank you.
I'll just say we need you in the profession. Less than 3% of dentists are African-American men. And so we need you in the profession as dentistry. We need you in the profession of oral health care. We need you in the profession of endodontics. So please, I hope that you enjoyed the conversation and will seek us out in our practices or at our schools for those of us who are teaching and faculty, and all of us are. And just know we need you. And please seek out your dentist, as already been stated, to make sure we can keep good oral health. And good oral health means good systemic health.
Thank you, Doctors Gray, Dr. Esther, and Dr. Scott. You have whetted our appetite and you've increased our understanding of endodontics and root canals. And so I want to say to you, thank you again for this evening and for being with us. I would like to say to you, our audience, thank you for spending time with us this evening. And we hope that we have dispelled some of the myths and misinformations out there, and that you know the truth about root canal therapy and the benefits of root canal therapy, and you can now make informed decisions. So we appreciate you for being with us tonight, and we hope that you will take this information back to your family, your friends, and to your network. And with that, I will say good night. We will say good night.
Good night.
Good night.
Good night.